All right. So, well, thank you, Paul, for the kind invitation and the organizer for allowing me to speak today on hepatitis C and B. Sorry, C from EASL. Oh, there it is. So here are my disclosures. I'm the Speaker Bureau Consultant for the following companies.
Yeah.
And in the next 40 minutes, we want to cover these three important aims. Demonstrate how the natural history and relative contributions to liver disease have been altered by hepatitis C therapy. Describe novel techniques to improve linkage of care and extend therapy to vulnerable populations affected by hepatitis C. And then clarify the milestones needed for hepatitis C elimination. So this is taken from a paper published in New England Journal of Medicine just last year. And it highlights that, just until recently, hepatitis B and C were really not on the radar screen for the WHO. Major causes of death were from tuberculosis, HIV infection, and malaria. And you see here that as projected the next decade or so, the chronic hepatitis B and C it plays a major role impacting survival and morbidity. As a result, as you know, the WHO has it in their radar screen to try to eliminate hepatitis C in the next decade by achieving a 90% diagnosis rate, having an 80% treatment rate, and a 90% curative ratio. It believed that this would translate to 90% less in chronic infections, reduction of death by 65%, and eventually reducing the burden of global disease from hepatitis C. Now, unfortunately, we have hepatitis C in a high prevalence rate in certain populations, particularly in people who inject drugs, MSMs, people in correction facilities. So these are still vulnerable patients that need our attention. So it's an interesting perspective what's changing hepatitis C, and this is a reflection of new epidemiology data, whereas we talk about how curing hepatitis C was important on an individual basis to prevent progression of liver disease to cirrhosis and liver cancer, improve morbidity and mortality, improve quality of life. And now the focus has changed from a medical concern to a public health perspective. And now if you look at most abstracts from AASLD and EASL, the focus is on the society benefits of hepatitis C cure, preventing onward transmission, and reducing health services usage and costs. This has been modeled in many studies. And this is a very nice study looking at treating people who are incarcerated, prisoners, showing the benefits of treating prisoners really extends beyond the prison walls. These individuals who are cured now will not transmit hepatitis C to the general population. Despite this lofty goal of eliminating hepatitis C, we have a lot of challenges and barriers. And these could be lumped to certain buckets. Testing, linkage to care, treatment uptake, and treatment adherence. But fortunately for all these barriers, there have been attempts and corrective measures to mitigate this, to extend care to the most vulnerable populations. A number of studies, and we're going to highlight a couple later today, but a couple of studies have looked at how can we simplify treatment regimens to make it as easy for people as possible. This is modified from a study by Doug Dietrich, who's been at the forefront of hepatitis C for the past couple of decades, looking at how we can simplify therapy by treating basic viremia, excusing the role of a genotype, and emphasizing the role of platelet count as a surrogate marker of advanced liver disease. Of course, in this model, you get to look for DDIs, and does require hepatitis B testing. So before we begin our discussion on recent publications at EASL and AASLD, I want to show this very provocative study that's really getting a lot of attention. And this is a paper that's in press in Journal of Hepatology, And it what looks at is at what is the global impact of delaying hepatitis C diagnosing. Unfortunately, in this model, because of delay of therapy across the globe, there is estimated that maybe an additional 70,000 deaths. The paper, the model depends heavily on the assumptions, and would invite you to please review this article. Very provocative, and it's receiving a lot of attention in the lay press. So going back to our aims of natural history, impact, and novel techniques to improve linkage of care, and milestone, we'll start with the first one, natural history relative contribution. So there have been a number of studies identify what is the impact of treating hepatitis C. And in this study here from Australia, looking at treating prisoners, they found that the major impact of treating prisoners is that it does lead to decreased prevalence of hepatitis C. And the argument is that by treating hepatitis C, this is also a preventive measure to prevent transmission among prisons. So this is taking hepatitis C from a societal perspective instead of an individual one, that we can stem the tide of new infection by treating patients already infected. This is what, I'll be honest, one of the first studies that I'm aware of outside of modeling that shows that treatment is also a preventive measure against new infections. I thought it was beautiful. This separate study from EASL was presented as a poster. And basically what it highlights is what we're seeing already in our hospitals. As you know, right now, morbidity and mortality of hepatitis C has come down significantly. And you've seen our liver transplant list. You heard from the panel before I started that alcohol is playing a major role. Hepatitis C is being dethroned as the most common risk factor for liver cancer, as the most common indication for liver transplantation, the most common cause cirrhosis. And this highlights that this also translates to decreased health utilization. You see here from the study from Spain that hospitalization for hepatitis-related complications have decreased and is expected to be close to nil in the next 15 years. This next couple of slides, I think is very provocative as well. And we take it for granted that Hashim El-Sarraj, in a landmark article over 20 years ago, highlighted the increase of liver cancer in the United States. In his landmark study published in the New England Journal of Medicine, he showed that liver cancer rates were increasing, and with the morbidity and mortality. And in fact, most models have projected that the peak will occur in the next 10 years because of all the cirrhotic patients. In this very nice study by Shields and O'Brien, they looked at liver cancer rates in the US. And now they're finding that we are peaking, but we peaked already in 2013, and the rates are coming down of liver cancer, coming down for the age groups of people between 35 and 49 and 50, 64. Whereas going up is people over 65 years of age. Now you can argue with me that this might reflect old hepatitis C baby boomers, but don't forget that Zubair Yunusi had a very nice paper published a couple of years ago where it showed that the most common risk factor for liver cancer in baby boomers and Medicare age patients was NASH. So, the good thing is liver cancer rates are going down across the globe, across the country, but for a certain age group, including people who are baby boomers, Medicare age individuals, there is an increase, and this may reflect old hepatitis C or even NASH. This is from a poster presentation, AASLD, and it highlights that, although we've got great treatments of hepatitis C, the rates of liver cancer going down, health utilization is going down, the liver transplant list is changing, there's no shortage of liver disease. I remember sitting in a chair next to Ron Pisoto, about 4 years ago, and he was telling me that, listen, we're going to be out of business. Curing hepatitis C is going to, eliminate the wait list of people on our transplant list. Unfortunately, this has been replaced. the viral hepatitis as an indication for liver transplant has been replaced by alcohol liver disease and NASH. So in addition, what the authors found is alcohol liver disease is increasing, not just in young adults, but look at this, in baby boomers as well. So alcohol liver disease right now in the United States can be argued as one of the most common cases for liver transplant in this country, as well as across the globe. And you heard from our last distinguished panel about the controversies in young individuals who present with alcohol hepatitis. So death and liver disease have not gone down with all the hepatitis C cure. If anything, they're going higher as a reflection of liver cancer, fatty liver, and alcohol liver disease as well. So the burden of liver disease is increasing. This is also a very nice study presented at AASLD this year. And what the authors looked at a very large cohort of people with hepatitis C and cirrhosis that were cured. And they stratified their 647 patients into 3 cohorts. People, all child class A, patients with child class A without previous liver-related complications, patients with cirrhosis who've had a liver complication but without liver cancer, and people who have cirrhosis with a history of liver cancer. And they looked at the incidence of liver-related events, looked at mortality. And so the take-home message is, if you look at independent predictors of outcomes, one thing all these patients have who've had a bad outcome is a diagnosis of diabetes. So as you remember from the last presentation on NAFLD, diabetes is a very bad thing. It's probably the single most important predictor of outcomes for NAFLD and NASH. And indeed, for particularly queried by your patients with cirrhosis have diabetes, because they're at risk for liver cancer, the complication, despite being cured of their hepatitis C. So now we're going to look at novel techniques to improve linkage of care and extend therapy to vulnerable population. And these vulnerable population right now are really a new face of hepatitis C. These individuals that are coming to our offices with hepatitis C infection. Many of the baby boomers have already been cured. Now we're faced with new hepatitis C as a reflection of this growing heroin epidemic that we're seeing across the globe. So these next studies are looking at treatment at this vulnerable population. Here's a very nice study by Lampertico looking at real-world analysis of people with hepatitis C who have psychiatric and substance abuse disorders. These individuals that, historically we wouldn't treat for hepatitis C. What about compliance? What about drug interactions? But using GP, these individuals had incredible high cure rates, the same as the general population, regardless of their diagnosis of being a PWID, of psychiatric substance disorder, of having alcohol dependency, and being unemployed. So in this very elegant study of a very large population, the cure rates are equally as high. These individuals who have substance abuse, psychiatric disorders, can be managed with multiple medications and achieve high cure rates, again, similar to the general population. So this is another very nice study, but this is a way to capture patients who are hospitalized. It's very hard to get patients engaged who are PWIDs, very difficult. So here's a method to maybe identify individuals who have been hospitalized, to capture individuals and get them linked to care. The take-home message is, despite this aggressive technique of identifying individuals, unfortunately, the linkage to care for hepatitis C remains very, very low. So although it's a very novel concept of identifying people who are hospitalized, unfortunately, it doesn't go far enough to get people tested and linked to care. It's still less than 50%, unfortunately. This next presentation was from Barcelona. And what it looks at a very large harm reduction center in that city. And they offer almost 1,000 PWIS screening. And one of the things is, despite our efforts, besides patients being enrolled in a harm reduction center, the acceptance rate to hepatitis C is just barely over 50, less than 50%. Most individuals have no interest at all. So offering screening is not sufficient. We've got to throw a larger olive branch. And so despite on-site screening for hepatitis C, acceptance remains below 50%. And initiation was also quite low as well. One of the things that I do want to comment on, and this has not been shown by previous studies, so I commend the authors, is in this harm reduction center, reinfection rates were quite high. So I think this is a very honest study showing a reinfection rate of over 10% in a very short period of time. So I appreciate the honesty of the study. Most studies have not shown reinfections this high. This is a nice real-world analysis. This is from a study presented from Seattle, also looking at continuity of care, predictors of treatment among PWIDs. A very large study looking at 338 patients and 376 in 2 time periods. And unfortunately, it really confirms many of our observations. And I'm sure from your own experience, that linkage to care and treatment initiation is very, very low. And it highlighted several important predictors of a lack of linkage to care, and that is the combination of PWIDs and being homeless is a very bad combination, The next study is called the HERO study. It stands for Hepatitis C Real Options. And I like this because it goes beyond just testing. It really shows how we could help the patient navigate the system. And in this HERO study, we took patients by the hand and we stratified 2 different methods. One method was using directly modified therapy for treating hepatitis C, like you do for tuberculosis or leprosy, what have you. And the other was a patient navigation system. This is a very large study, almost 400 patients in each arm. And here are the demographics showing that the most individuals were living in an unstable living situation. In other words, they're homeless. A third of patients had regular job or informal work. The majority were involved in some opioid treatment program. And about 1 out of 5 were co-infected. You see here that a urine drug screen results at baseline, many were on opiates, cocaine, amphetamine, etc. Unfortunately, this confirms observations that this vulnerable population that are really driving infection rates have issues with linkage to care. But once they get linked to care, in the modified ITT, the cure rates are about 3/4. If you look at the protocol analysis and focus on patients who completed therapy, were not lost with therapy, the cure rates are approaching now the general population. In this study also, I want to commend them because this study shows that adherence makes a difference. Like for any medication you take for any situation, whether it be bacteria for infection of a urinary tract or pneumonia, if you don't take your drug, it ain't gonna work. And this highlights the increased efficacy, sustained viral response with adherence. So it's treating patients, these vulnerable populations is a challenge. We need to develop new methodologies. These are 2 steps in the right direction. Patient navigation, as well as direct above therapy. I do want to also highlight that if you look at the slide here, if you look at the SVR on people using drugs, If you see here on the 5th row, injection per day, the SVRs were 64%, a lot lower than are presented in other presentations and publications. If you also look at ages, on the top row, people less than 40, which are the majority of people who inject drugs, their cure is also very, very low, 65%, a lot lower than general population and significantly lower than people over 40. So keep that in mind when you hear studies highlighting treating patients who are using inject drugs or are homeless, that the results are not necessarily as rosy when you start stratifying data by different predictors. This is a nice study by Rodriguez and Thais and presented this year, looking at treating homeless individuals. And to make a long story short, if you look at the characteristics, many had drug use, many had psychiatric disorders, many were still IV drug use, but they had a high adherence, and the cure rate was incredible, 100%. We at UCLA work with the homeless clinic in downtown Los Angeles, and we also published a paper last year on treating homeless individuals. Our cure rate were very, very high, but we did directives for therapy, and the patients who didn't respond to therapy are people with loss of follow-up. Here's another study looking at GP and substance use disorders, and just to make a long story short, if this is very nice because this is one of the few studies that I see that the subgroups are broken down by cocaine use, heroin, marijuana, looking at alcohol, PWIS, non-PWIS, and you see across the board. In these select patients, the cure rates are above 90%, approaching that what you see in the general population. Next, we can talk about milestones for hepatitis C elimination. This is the last part of my talk. And this is from a presentation at EASL showing that some countries are on track, to eliminate hepatitis C. Unfortunately, 3 countries on track to eliminate hepatitis C by 2030. Canada, Germany, and Sweden. And unfortunately, here in the U.S., we're not looking at eliminating hepatitis C for the next several decades. Now, this is probably going to change because there have been a lot of studies highlighting that barriers in the U.S. have been decreasing. Medicaid restrictions for fibrosis has improved significantly, and now only a handful of states only a handful of states have fibrosis restrictions. Some of those include Texas and Iowa, but for the vast majority, there's more fibrosis restrictions. Other barriers in the United States that have been improved are specialty. And as you know, when these DAs were first approved in California, some Medicaid plans require a specialist to prescribe the medication, ID or GI hepatologist to prescribe medication. California, that's no longer the case, and across the country, that's slowly going away as well. We're seeing micro populations where hepatitis C may be eliminated. And in this here very elegant study from Spain, and by the way, Spain's done a good job of really treating prisoners for the past several years. They've had a number of population studies showing their high cure rates as high as general population, and they're predicting hepatitis C could be eliminated in this population. In the U.S., we still struggle with treating prisoners. Most prisons have an opt-in for screening purposes, not an opt-out, so it does pose some barriers. But looking at treating prisoners in the United States, it's been very difficult. There's a lot of rules and restrictions about accessing that data. So this is a nice study called MINMON, Minimum Monitoring. And this is a global study, of almost 400 patients. And basically in this model, they look at giving treating people with hepatitis C or treatment naive with no evidence of decompensated liver disease with 12 weeks of soft fail. It's minimum monitoring, so patients are given all tablets up front, all tablets. You confirm the infection with the viral load, but no genotype required, and no blood test during therapy. And this require minimum monitoring. And they found that doing this globally, so here are the countries, US, Brazil, South Africa, Thailand, Uganda, you see the cure rates was an astonishing over 90%, 95% to be exact. They did find some predictors of a lower SVR, and I want to highlight here again the issue of age. People in age between 20 and 29, I had a lower SVR rates than people over 30, 59 and people over 60. And it did show, however, that people, current drug users of 92% achieve an SVR. So not too shabby. Again, at times it's hard to reconcile these results with the prior ones, and it's got to do with patient selection. The big concept is minimizing treatment. And I like the study by Ed Gain that was presented at AASLD. And basically what it looked at is that concordance results between the SVR4 and SVR12. And I got to tell you, he found a very high concordance rate. So basically your patients were very anxious about the results, very anxious about whether they achieve SVR12 or not, or patients who you have trouble following up with them. People who are homeless or drug users who may not come back, or people who are young. There is some confidence with the SVR4 that it's a highly predictive SVR12. Basically, almost every single patient SVR4 were cured as well. This next slide is a little complicated. And I think for me, this is very controversial, and I struggle with this presentation at EASL from this year. But basically what it shows is, you could have cure rates, at least 80% in people who completed 1/3 of the therapy. I have a lot of trouble with this. And I was reading again last night, and I question including in today's presentation, because the 1/3 is actually a big interval. It's 1/3 to 2/3. So that tells me a whole lot. And I think it's a wrong message. We want to encourage adherence, not minimize it. Like everything else, you got to take your medication. This is my last slide, and looking at what we could do in our own offices toward this goal of elimination. How do we get patients back to us who've been seen before and with diagnosed hepatitis C but has not followed up? We're doing this here now at UCLA. We're going through all our records to see who had hepatitis, who've not been re-engaging us. And this study here looked at two different strategies. They're looking at either calling patients up and remind them and get them back engaged again, or simply writing them a letter. Of course, writing a letter is a lot less expensive, less cumbersome, but what is the end result? And it turns out that if you want to re-engage your patients who've been lost to follow-up with hepatitis C, phone calls are significantly more effective than simply writing a letter. It's a lot more involved, but at the end of the day, it's a lot more effective. This was a randomized clinical trial from Spain, and it highlights that we need to do a better job with more effort to get patients re-engaged again. So in conclusion, Paul and all my good friends and colleagues, hepatitis C has emerged as a public health concern among the homeless, incarcerated, and PWIS. And we've got to do a better job of engaging these individuals. These individuals are not engaged in the healthcare system that we're accustomed to. They are engaged in the healthcare system, but different from what we see on a daily basis. High sustained viral responses, higher rates can be achieved in these vulnerable populations. Survivors improve, including those with cirrhosis, but the risk of liver cancer persists. And indeed, despite all these barriers to linkage of care and treatment and adherence, we still remain committed to hepatitis C elimination that we believe can be achieved in our lifetime. Thank you, everybody. Thank you, Paul.